So good afternoon and welcome to Riverside University Health System Diversity, Equity, and Inclusion Grand Rounds. It's a little bit after 12 and we do have a packed schedule, so we want to go ahead and get started. My name is Jeffrey Leung and I'm part of the RUHS Equity and Diversity Task Force. And we're really excited to have sort of the first system-wide grand rounds on diversity, equity, and inclusion today. Just to let you all know, we are recording, and if you have questions, please use the chat box or the Q&A box at the bottom of your screen. We do know that this is not a new topic for many of you. RUHS, sort of given our role in supporting vulnerable communities, we've had a long-standing history of working on disparities. And more recently, through the state waiver programs, there's also been a lot of work on this as well. But the pandemic has really highlighted, existing disparities and in many cases exacerbated existing disparities, especially among our vulnerable communities, which makes sort of the topic today even more relevant. So I do want to pass this over to Dr. Kumar to say a few additional words and introduce our speakers. Thank you.
Thank you, Dr. Leung. Good afternoon, everyone. I'm Vikram Kumar. I'm a pediatrician by training, and I'm also the Chief Health Information Officer here at RUHS. Today we are very fortunate to have three fantastic subject matter experts and speakers. So to kick us off, we have Dr. Marcia Penny, who's the Deputy Director for Public Health with a focus on equity. And Marcia will be sharing a county perspective to some of the diversity, equity, and inclusion efforts. And to follow that up, we have Dr. Takashi Wada from IHP. He's the Chief Medical Officer at the Inland Empire Health Plan. And Takashi will be speaking to the health plan efforts on disparity reduction and DEI. And to close this off, we have Giovanna Giuliani, who's the Executive Director for the Safety Net Institute through the California Association of Public Hospitals. And Giovanna will provide us the perspective from the Safety Net Institute, the California Association of Public Hospitals, and also from the state. And we do have some time towards the end reserved for a roundtable / questions. So if you have any questions, feel free to post them in the chat channel and we'll try to answer those questions. So I'm going to turn it over to Dr. Penny. So Dr. Penny, it's all yours.
All right, well, thank you so very much. All right, so feel free to advance the slide and we will get started. All right, well, good afternoon. I'm Marcia Penny and I'm one of the deputy directors here at our local health department with Riverside County. I have the pleasure of getting us started this afternoon. And my talk is going to be a little bit about the what of health disparities and health inequities, while our other great speakers get to talk about how they're doing what they're doing. So I'm really looking forward to those speakers as well. Next slide, please. All right, I have nothing to disclose. All right, so a little bit about who we are in public health, just to kind of help provide some context. As the health system, we're a great big family, and we've got 4 specific areas within our family. I am housed within RUHS Public Health, which is one of 4 other groups that include behavioral health, our medical center, and our community health centers, also known as our CHCs. Next slide, please. A little bit about public health. So we are responsible for the health and well-being of all of the residents and visitors in Riverside County. And we can see here on the slide, our mission aims to promote and protect the health of all of our residents and visitors. And we do that by a number of ways. We have a great staff of a little over 700. We've got 11 branches and divisions, as well as a number of programs and services that we provide in partnership with the other members of our system. But our aim is to work to reduce health disparities. That's one of our aims. We focus on healthy people. If you've ever heard of the nation's goals, Healthy People 2000 is where it started, Healthy People 2020, and Healthy People 2030. And all 3 of these, as examples, had a goal aligned with reducing health disparities and advancing health equity. And so at this time, there are 5 national goals. We went from initially 1 goal, then to 2 goals, and then we just continue to add the numbers of goals under our nation's health goals. But under Healthy People 2030, Goal 2 aims to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. And so we really focus on that within our programs and services in public health. How do we do that? I've outlined, listed the goal here for you, but there are a number of objectives. There are almost 2,000 objectives tied to this goal, and we use those within our programs and services to really help us have this laser focus on the work to establish health equity. Next slide, please. All right, so health disparities. I would just want to set the tone a little bit around health disparities and how that leads us to health inequity. Health disparities aren't new, and we've seen some significant changes in our life expectancy, for example, in our among the residents in the United States, which is fantastic. The fact that our life expectancy has gone from an average of 48 years in 1900 to 78 on average today. And of course, there are still some gaps and differences there. Although we've seen that 30-year increase, not every single racial ethnic group, income group has experienced that increase to the same degree. And so we still see these huge gaps or disparities that exist, whether we're looking at it by racial ethnic group, whether we're looking at it by gender group, geography. I mean, we see that there are differences in life expectancy based on where you live, based on your zip code. And that's extremely concerning. And those things have not changed over time, unfortunately. We've seen narrowing of the gaps, but the gaps still persist, and they're worse in some areas. You know, right now, just as a personal note, I think about children from the day they're born, average life expectancy is 78, but depending on the racial ethnic identity of that child, right? An African-American child will live on average, male, 4 years less than their white counterpart. And that changes depending on where you live in the United States. In some areas like Washington, D.C., a Black male in Washington, D.C. has a 15-year life expectancy difference between their white counterpart, and African-American females will have 11-year difference between their white counterparts. And that's a reduction in life expectancy compared to their white counterparts. And the Washington, D.C. area is just one example. And so these disparities continue to persist, and we have to do everything we can in terms of partnering together to address these. Next slide, please. And so the number itself is problematic when you think about life expectancy, but this also costs us financially and economically. The indirect costs associated with loss of life prematurely or these differences in life are pretty substantial and significant. So we lose human capital, and that's what's extremely concerning about these gaps. Next slide, please. So I want to bring us to a conversation about the difference between disparity and what many of you are probably hearing as well, which is inequity. These disparities are the differences in outcomes. So these are enumerated differences, right? So I mentioned life expectancy a moment ago, that we can clearly see differences in average life expectancy across racial ethnic group. And so that's the disparity. However, a concern, what most of us should be most concerned about, is the health inequity, because these are disparities that exist that shouldn't exist. They exist as a result of differences in social determinants of health. So differences in where you or I live, learn, work, play, and pray. Those differences are what result in these health disparities that we're seeing. Next slide, please. So here's just an example of just kind of help this discussion around, well, what do we call things? Do we call them disparities, or should we call them inequities? And so bear with me, a little bit of older data here, but the trend is still the same. We haven't seen much change at all. This is healthcare disparity example for Riverside County, in particular, looking at cases of breast cancer between the years of 2005 and 2009. And what you should see is a huge disparity between breast cancer across sex. So female breast cancer cases compared to male breast cancer cases. That's explainable. It makes sense, right? Females have more breast tissue than males, so it's not a surprise to see these huge gaps or differences that exist there. Next slide, please. And now this is an example of a health inequity. The fact that we see differences, now this is specifically looking at breast cancer mortality among women in Riverside County. So now we're looking at one sex, and then we're looking at it stratified by race, ethnicity, and we see these huge differences. And let me explain a little bit about what these differences could mean. We know that white females are more likely to experience breast cancer. They're more likely to be diagnosed with breast cancer compared to their African-American female counterparts. However, when we look at breast cancer mortality, African-American females are more likely to die if they are diagnosed with breast cancer. So that's an inequity when we think about some of the things that may contribute to it, such as later diagnosis in African-American females compared to their white counterparts, or difference in treatment options associated with some of the biases that we see in the healthcare system. And so the aim is to really understand that a disparity is a difference that can be explained, but an inequity is a difference in social determinants, differences in where we live, what access to services we have, what resources we may have, differences in our employment opportunities, differences in income, differences in access to services and care, all of those things that we see that happen to exist that are tied to structural inequalities, and those result in these disparities that we are seeing. Next slide, please. So the tragedy of health inequities, I mentioned earlier that life expectancy, we see these gaps in life expectancy, but also think about the impact of the social determinants of health. So where you live, learn, work, play, and pray, the impact of those on the numbers of deaths that we experience every year. Now, unfortunately, the National Institutes of Health has not updated this data. However, it's still impactful data. If you think about it, we haven't experienced a change. We haven't seen much improvement from this data that was released, a study done in 2000. 75% of US deaths were attributed to social determinants of health. And as you can see on the slide outlined here, the numbers of those that are associated with different social experiences like education, low education, racial segregation, low social support, and so on. But think about today, COVID mortality. So at this point, almost 750,000 people in the United States have died as a result of COVID. And if we still apply, if we're able to extrapolate and apply that 75% social determinant association there, that's about 560,000 people who have died from COVID from preventable causes tied to social experience, tied to where they work, right? Being an essential worker and still having to go to work every day, not having access to maybe childcare, or not having access to resources that may reduce their risk of exposure to COVID, and so on. And some of the chronic disease issues that we see across some of our populations, increasing their risk then if they do have COVID, experiencing severe illness and ultimately mortality. Right, so the social determinants of health are extremely important in our ways of reducing health inequities and ultimately health disparities. Next slide, please. So this illustration here comes from the Bay Area Regional Health Inequities Initiative. We call it BARHI for short. BARHI is a group of counties in the Bay Area. There are about 7 health departments in the Bay Area that got together and established BARHI almost 20 years ago, actually, in fact. And so the aim with BARHI is to really highlight what we're calling the upstream versus the downstream approach. So in the illustration, what you should see, hopefully, is that on the right side, it illustrates downstream. Downstream is where we've spent most of our time working. That's where the disparities exist, right? So the differences in life expectancy, differences in health outcome, differences in mortality, differences in healthcare access and such. So we're seeing that on the downstream side. At that time, at that point, the disparities already exist, right? It's pretty prevalent at this point. And this is where most of us we've spent for years, most of our time and most of our work, but we have to think more upstream. We have to think about what are the systems that feed into this downstream outcome. So think of downstreams as outcome and upstreams as the inputs. And so our focus should be on, for addressing health inequities, should be addressing the input. So looking more to the left of this illustration, looking at the social inequities, looking at the systemic issues, policy implications, and how we can change legislative policy and advocate, engage in more advocacy. Those are ways of addressing health outcomes in a more fruitful and productive way. And think about it this way. I don't know if any of you have heard the babies in the river parable before. If so, please bear with me as I share it with you all today. A village next to a river, and a gentleman is fishing. He lives in that village and he's fishing at that river, and he sees a baby floating down the river. And so, he's alarmed, goes and rescues the baby. A couple minutes later, another baby's floating down the river. And so he wrangles people who live with him in his village to help rescue all of these babies that now just seem to keep flowing down the river. And then it takes one person who says, I'm not going to help you rescue. You've got enough folks here that are obviously helping to rescue. I'm going to move upstream. I'm going to go up to the top of this river to figure out who's throwing these babies in the first place. And then we can stop them from coming down the river. And that's really what we need to be doing when we think about upstream approaches to addressing health disparities. Focus on more upstream, addressing more of these social factors. Because in all, when we think about life expectancy, the downstream approaches, we think about health behavior, decisions that people are making, access to care, genetics. Those only explain 20 to 30% of life expectancy and health outcomes and mortality. That means 70 to 80% are explained by these more upstream and social experiences that people have every day. Next slide, please. And here and on this slide, you can feel free to hit enter for me a couple times. Thank you so much. These are just a few examples. And once more, there we go. These are just a few examples from the California Department of Public Health's Office of Health Equity. They put together a report called the Portrait of Promise. And in the Portrait of Promise, they looked at exactly what I just described a moment ago, social determinants of health, and what we're seeing as differences that are happening early on before we get to these major health outcomes that we're certainly concerned about addressing. So things such as a higher proportion of Asian and white third graders reading at or above reading level, right? So reading at or above the near standard compared to their African-American and Latino or Latinx counterparts. Or Latino or non-white populations are more likely to live in areas with a high burden of pollution. Or about 40% of African-American women report experiencing racial discrimination compared with only 8% of their white counterparts. Teenager arrests for marijuana possession are disproportionately affecting boys and African Americans. And they look at usage pattern across racial ethnic groups and gender groups, and they find that the usage patterns do not reflect the prosecution patterns that we're seeing in the rest of that we're seeing in our state. Also, access to health insurance or usual source of care is lower among racial ethnic groups with serious psychological distress. And then lastly, non-white male students are underrepresented in our California higher education. So these are just some examples of important areas of upstream that we need to address and should be addressing to reduce the health disparities outcomes. Next slide, please. So why should we care about disparities and inequities? Well, because if you think about it, each of us, we're born and we didn't ask to be born vulnerable. We didn't ask to be born with a lower life expectancy. I think about my two kids. I have two boys, 10-year-old and 11-year-old, African-American males. And I think about the fact that on average, their life expectancy is 4 years less than their classmate, than a white classmate, right? Nobody expects to have that type of outcome, to be confronted with that as a potential outcome for them. And additionally, we think about historically, we talked about disparities 10, 20, 30 years ago, the conversation was minority health, minority groups and health outcomes. But if you think about it, it's expected that by the year 2040, most of our population will be people of color. So the experience of the minority will be the experience of the majority. We're not addressing health disparities for smaller groups. These are going to be much greater issues. And we're already experiencing them now as great issues, but they are just going to grow and become much larger issues that impact even more of our population and our communities. So every life is precious, and it's important that we do what we can to prevent negative health outcomes for our communities. Next slide, please. So thinking about tackling health disparities from a public health perspective, our next speakers will do a fantastic job of describing how they're tackling them within their organizations and agencies. And I just want to describe what we're doing here in Riverside County Public Health. Moving to a more upstream approach across every group, regardless whether you're working in healthcare, whether you're working in public health and other agencies, probation, law enforcement, trying to move upstream is important for all of us. So that's one of the first things to do. We also have had a wonderful opportunity. About a year ago, our Board of Supervisors, so our Riverside County Board of Supervisors, declared racism and health inequity as a public health crisis. And what that did for us was it allowed for us to engage other county departments and say, come on board. We've been doing that before. We've been doing this work for years, and we've been inviting folks for years to join us. But now we're charged by our county leadership to all work together to address health disparities and health inequities. And so it's a great opportunity. We're forward looking right now, and we're really excited about what's to come now that everybody's abuzz about this resolution and what this means for all of our county departments, our over 40 county departments that can now engage directly with each other to address this and focus on teaching other areas that health outcomes are one thing, but many of these outcomes are also negatively experienced and impacting the other county agencies and the work that they do. Next slide, please. And so what we've done here in public health, we're looking at a three-pronged approach. All right, we're looking at how do we internally make sure that we're all on the same page, we're doing the work necessary to address health inequities. And the first thing we did was focus heavily on an organizational transformation. Get everybody to understand that health inequity is a concern for our department, it's a concern for our county, it's a concern across the state and the nation, and we're engaged in this and we're invested in this work. And so through that organizational transformation, we've developed trainings for our staff. We actually developed a 24-hour health disparities, health inequity training called Improving Health for All. And all of our staff are required to go through that 24 hours training. And it was developed in-house in partnership with several other local health jurisdictions. And other local health jurisdictions have grabbed onto these tools and resources and used those as well. And then partnering with our county departments. So countywide, working with other county departments and agencies. We have task force and coalitions. And this Grand Rounds is another example of that partnership with other sister groups and agencies, as well as moving towards working out in the community. So community-driven approaches. Working with CBOs, working with FBOs, so faith-based organizations, working with schools, working with businesses, working with healthcare providers. We're working with so many different groups now and bringing them on board into some great discussions, creating coalitions and task force that will have so much power and strength behind the work that we aim to complete. All right, next slide, please. So I just want to close with a quote from Dr. Martin Luther King. He had it right in 1966 when he said, "Of all forms of inequality, injustice in healthcare is the most shocking and inhumane." And that still stands today. Let's not forget the history behind this work as we continue to build a better, equitable, and inclusive future that's rooted in social justice. All right, next slide. All right, thank you so much for your time, and I want to hand it off to our next speakers.
Great, thank you. So I am up next. I'm Takashi Wada. I'm the Chief Medical Officer for IEHP. Next slide. The speaker disclosure. So Dr. Penny did a great job setting things up and talking about sort of upstream factors and social determinants of health. So I'll go through those pretty quickly because of that overlap and really focus a little bit more on the health plan role around data, identifying the problem, some of our local data with our IEHP membership, and what we do with that data and how we develop some interventions to address some of these disparities. Next slide. Just real quick, who we are. We're a nonprofit public Medi-Cal and Medicare health plan here in the Inland Empire. We cover both San Bernardino and Riverside counties. Our mission is to heal and inspire the human spirit. From our mission definition, our work in this space starts with those who are most vulnerable, who face the greatest disparities, who are furthest from equity, and who have more obstacles in the way. Through them, we advance quality of life for all. And our vision is that we will not rest until our communities enjoy optimal care and vibrant health. Next slide. Just real quick, we are a health plan. Of course, sometimes health insurance doesn't have the greatest reputation, but as a public plan, it really allows us to kind of focus on our members and on quality. We don't have shareholders like the commercial health plans do. And so really our goal is to do what's best and what's right for our members. As you can see from this slide, we have 1.4 million members across the two counties. Most are female. There's a good proportion, about a quarter, that are Spanish speaking as their preferred language. In terms of ethnicity, a large portion of our membership is Hispanic or Latinx, with smaller numbers of Caucasian or white and African American members for us. Next slide. Just some quick definitions. Dr. Penny again set this up very well. Disparity is really the difference. These definitions we just pull from the CDC and talks about preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health. And then health equity as the opportunity to attain his or her full health potential, and that no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Next slide. This is very similar to Dr. Penny's bar high slide, again, talking about social determinants of health. Again, in healthcare, we've typically focused on that column on the far right in green with the healthcare system and access and quality. And of course, we need to continue focusing on those things. But I think slowly we are moving further to the left. And maybe these are not things that we take on in healthcare as a lead entity, and certainly not by ourselves, but we need to have a role and we need to have a seat at the table. So when we're talking about economic stability or the neighborhood and physical environment, education, food, of course, housing, some of the other community and social issues, they absolutely all have an impact on health and how one experiences health. And so we need to be moving into those upstream areas if we're ever going to get the type of outcomes that we want to as a healthcare system. In the middle there, you see racism, discrimination. These are all factors that influence all of these social determinants of health. So as you'll see later on in the presentation, as we think about our types of activities, it's not enough to just focus on sort of the far right side, looking at our outcomes and their interventions that we still do across the board, but we have to move upstream and try to address some of the other issues, not just in these areas, but also around trust and engagement. So next slide. So what is a managed care plan role in disparity reduction? So, we are the payer. And one thing that we have is data. And that's very important to help identify, quantify the problem and issues. And so if you think about it, every piece of the healthcare system, of course, delivers some type of service and they want to be paid. And so that comes to the payer. So we have all that information and data. If you're on the public health department side, and I used to be in that area as well, you may have population-based statistics, but it's very difficult to get it down to an individual that you can contact. If you're part of a healthcare system on the provider side, you have great information in your electronic health record systems, very detailed, but it's only what's being provided within your system. You may not have information if that patient is never even coming in the door. And we know that that's a very big issue. You also might not have information if they're getting services outside of your system. And so that's one thing that we have, across our membership is we know exactly where they're hitting the different components of the system. So in your EHR, you may prescribe a medication and you would have that record, but you might not know if they actually went and filled it at the pharmacy, whereas the health plan, we paid for that. So we would have that data. So we have very rich data. There are some limitations, of course, with any data. Race, ethnicity data is oftentimes self-reported. Sometimes people don't fit into neat categories. Sometimes there's pieces that are carved out for services that people get through the county systems. So the severe mental illness, for example, some of that data is carved out to us. But in general, we have that information and we can actually get it down to the individual level, which I'll show shortly. Access to care, quality, building trust, these are all things that we work on, again, as a health plan. We have certain leverage as a payer, so we have payment incentive models that we can use to try to change behavior of our providers, as well as of our members. Next slide. We also have some requirements. And so one example is at the state level, we're required to do annual health disparity reports. We have to do health equity performance improvement projects. We do population needs assessments. There are all kinds of metrics that we track, HEDIS and CMS, child and adult core sets. And we also do customer experience and satisfaction. surveys and assessments of our membership. And so again, this all just kind of adds to the data that we collect. Next slide. So now kind of getting into what we do with all this data. And so we have dashboards that we look at regularly. And this is just an example of pediatric preventive care. And we break it down by age, by sex, by ethnicity, language, homeless indicator, regionally, geographically. And we have all these metrics that we track and analyze for disparities. And we have very complicated algorithms that do that actually look at p-values that are statistically significant. And as an example, for this pediatric preventive care, Black ethnicity comes up as a disparity and is flagged across all of these measures. Same with homelessness. You can look at immunizations, again broken down by specific metric and by demographic. Next slide. Same thing for women's health. Again, we track all of these metrics: breast cancer screening, cervical cancer screening, chlamydia, prenatal postpartum care, and then we break it down by by age, by race, ethnicity, and then this allows us to develop more targeted interventions, which is very helpful in the age of limited resources. Next slide. Same thing for disease management. Again, your asthma medication ratio, controlling blood pressure, diabetes care. That you can look and see on the text on the left-hand side, there are disparities that we see for males geographically in San Bernardino. For blood pressure, there's African American population that shows up as a disparity. In diabetes care, the American Indian population, and in Riverside for diabetes and blood pressure control. Next slide. So we can take this sort of population level data and actually drill it down to the specific member so that we can target these interventions. And so we use GIS mapping. And so you can look at this and we can identify our members based on their address and get down to where we have some of the biggest issues. So this is doing filters for American Indian, Samoan, and Alaskan Natives, again, for diabetes control. And we can see where we are having the biggest issues. Each hex in this slide is 5 square miles. Next slide. Same thing for pharmacy management. Again, I won't go into details in the interest of time, but we also track statin therapy, appropriate statin therapy, and adherence. Next slide. Behavioral health as well. We do the same for behavioral health, looking at medication management, follow-up after a visit for mental illness, looking at all the disparities, again, broken down by all the various demographics. Next slide. The hot topic, of course, is COVID. We look at our vaccinated membership broken down by race, ethnicity, and we can see here the African American population is at the lowest percent of vaccination rate in our IEHP membership. Next slide. We can also look at cases and case positivity per 1,000 by ethnicity. Again, on this slide now, you see the Hispanic population is actually having the highest rates within our IEHP membership of COVID positivity. Next slide. Same thing, we can actually drill this down to the individual level and where they live and see where we have geographic issues to develop targeted interventions and programming. This goes down to the square mile. These are new COVID cases as of last week. And so we can see where we may be having an outbreak and then develop messaging, reach out to trusted partners in those areas to help us either with communications or developing pop-up clinics. And of course, we work with all of our partners like the counties on those types of efforts. Next slide. So this is just an example of some of the activities that we perform, again, trying to think about moving more upstream. So controlling high blood pressure in the African American population, partnering with the community, looking at food, immunization pilots, using a promotora model or community health workers, again, trying to develop trust, as a health plan, sometimes the messaging isn't received all that well coming from us, but if we engage members from the actual communities and those subpopulations to act as health coaches or health advocates and health navigators, that can help us to address some of these more upstream issues. We're doing a lot around homelessness. So again, we have programs around homeless youth. We've partnered with various organizations around providing weekly showers for individuals, for example. Next slide. Within COVID, again, we look at all the data, we use that to develop our strategies and pop-up clinics and specific targeted messaging. We've worked with the African American pastors to help us develop public service announcements. Health equity and social determinants of health. Again, we have a housing program ourselves. We're promoting adverse childhood experience screening through our providers. We're reaching out to the BIPOC community, that's the Black, Indigenous, people of color, LGBT, using community health workers from those subpopulations to help us develop specific interventions. Through our community resource centers, we do exercise nutrition classes, and then we co-locate service around employment assistance and other social services. So again, maybe we're not the lead entity on some of those upstream issues, but we partner and co-locate them with the rest of our activities. As you know, a family, a mother that has multiple children has to take buses to get to our community resource centers or to doctor's appointments, has to take time off from work. It's very difficult. And so the more we can kind of bundle things together to make it easier for them, that's how we can get better engagement. And then the last thing I'll talk about real quick is CalAIM, which is a multi-year initiative led by the state. We'll be implementing this in January 2022. It will help us through Medi-Cal and IEHP address issues like social determinants of health. We'll be able to cover things like housing navigation, medically tailored meals, home modifications, and there's enhanced care management that we'll be supporting using community-based multidisciplinary teams through partner agencies. I think that's my last slide. So thank you very much. I think we're holding questions to the end. It was great speaking with you, and I'll certainly stay on the line to answer any questions. Thank you.
Great, thanks, Dr. Wada. Good afternoon, everyone. I am Giovanna Giuliani. I'm the Executive Director of the Safety Net Institute, or SNI. And I'm going to round out today's remarks by offering a state level perspective on health equity efforts. Next slide. No disclosures. So first, just very briefly, I want to start off by providing a very brief overview. For those of you who are not familiar with CEPH or SNI, we are the organizations that represent you, the public healthcare systems across the state. CEPH is the official trade or membership association of the public healthcare systems and focuses on policy, advocacy, and finance. And SNI is the programmatic and performance improvement partner of CEPH. And through our multiple roles, we support the membership to improve the care they provide for the patients you care for. Although we are two technically separate organizations, we work extremely closely hand in hand on a daily basis. Next slide. So just a quick overview of what do I mean by public healthcare systems? These are the 21 public healthcare systems that we represent across the state. Just a side note that later on you'll be hearing me talk about 17 public healthcare systems, and that's because in the large programs like PRIME and QIP that I'll touch on, LA and San Francisco report as one system rather than by each of their individual hospitals. So that's a little confusing sometimes, so I wanted to set the record straight there. Next slide. So with that overview, I am going to turn to summarizing what SNI has done at the state level to advance health equity in partnership, of course, with all of you, the public healthcare systems. And SNI plays 3 roles in support of its members. I'm going to touch on the first 2 that are circled here. and regarding how we've advanced health equity by informing and shaping policy and by providing performance measurement and reporting expertise. And in this case, I'm really going to focus on the development and implementation of two key and impactful programs called PRIME and QIP. Next slide. Dr. Kumar, Dr. Leung, at the very beginning talked about how this is not a new field, of course. Health disparities, you guys as leaders, safety net leaders have been talking and thinking about this for decades. And SNI also focused on health equity prior to 2015. But for the purposes of today, I'm going to kind of start my story with 2015 with PRIME. For those of you who aren't familiar, although PRIME was very large, and for many of you are familiar with it, it was a P4P program, part of the Section 15 Medi-Cal 2020 waiver. And there's a link here for you to learn more about that if you want to read more about PRIME. But the gist for PRIME was that it provided massive financial incentives for public healthcare systems to meet year-over-year improvement targets on many measures of clinical quality. But for the purposes of today's discussion, PRIME also included incentives to collect and act on real and SOGI data, and real and SOGI data is written out there in case you don't know what I'm referring to. And this was really, to our understanding, the first of its kind in the country to incent collection of this type of data in this standardized fashion at this scale. So before PRIME, most systems or all systems were required to collect race, ethnicity, and language data at the OMB levels, which were pretty high level. And then, as you guys know, there were pockets of local disparities efforts happening at each of the systems individually across the state. But then what happened with throughout the 5 years of PRIME was that the standardization of data collection and the accountability increased significantly. So real data was shifted from the higher level OMB categories to more detailed race ethnicity categories. So you could really understand at more specific levels what the data was showing in terms of health disparities. And then it rolled up across the state in a standardized fashion. So you could compare apples to apples from one public healthcare system to another. It also incented collection of SOGI at this scale for the very first time, sexual orientation and gender identity data. And then it also required systems to take the data they were collecting, look at what it was showing them in terms of healthcare disparities, and then develop a disparities intervention plan and act on it. Next slide. So what happened as a result of PRIME? Well, look across the top, you can see that in terms of data collection, it was a massive change over time. Nearly 700 additional patients had real data collected for them and completed for them, and nearly 400,000 patients across the state of California had SOGI data collected for them. And the bottom two graphs just show change over time from the beginning of PRIME with the gray dot to the end of PRIME with the blue dot for each individual system. So each vertical line shows the beginning and end for real data completeness and SOGI data completeness. So a lot of movement statewide in terms of collecting data in a standardized fashion and being able to really understand what we mean by disparities and inequities. Next slide. So then, I mentioned that systems had to create disparity reduction plans. So a system had to take the data, look at it, figure out what they were going to focus on, and develop and implement a plan. And so what this slide shows is the measures that are listed at the top, and then the priority populations that were selected by systems to work on. And based on the little bubble on the top right, based on data prior to COVID, because as you guys know, everything went crazy when COVID started, 13 of 17 systems had met their improvement targets for their individual project that was selected. Next slide. So what happened after PRIME ended? It ended in 2020. We obviously, and the state didn't want to either. Nobody wanted to kind of lose the momentum that was built up in PRIME of collecting this data for the first time, acting on it in a really structured way. So as we designed a new version of what's called the Quality Incentive Pool, or QIP, there's a link there if you want to learn more about that. we were preparing for the transition out of prime into this new version of QIP for 2021. And so what we developed in partnership with all of you, feedback from all of you, and in partnership with the state, really built on the foundation laid in prime. So one of the key elements in QIP is that in 2021, it now has required reporting of stratified race ethnicity data for 5 priority measures within QIP. That reporting will likely expand in future years, and then the data will be used to identify future P4P targets, and I'll talk about that in a second. But also, in addition to this required reporting on 5 measures in QIP, it's also beginning to build performance targets for race ethnicity subpopulations into the measures. Well, what do I mean by that? Let's take a look at this chart, and I'll just quickly walk us through each year. I will offer that this is somewhat complicated, but so people can feel free to reach out to talk about it more if they have questions. But in 2021, there is, and in future years, there is a required improving health equity measure. So every system must work on one improving health equity measure. It's a standalone, meaning it's not part of another measure. It's entirely on its own. And for simplicity purposes, we all agreed across the public health care systems and with the state that every system would work on the diabetes poor control measure this year for those 2 priority populations listed there. Going into 2022, what will happen is rather than diabetes poor control being the standalone improving health equity measure, now diabetes poor control, which already exists within the QIP as its own measure, will integrate the targets for those priority populations in the measure itself. So now diabetes poor control will have 3 subrates that systems have to meet targets on: the total population, Black, African American, and Hispanic Latinx. So now we're integrating that, and we're saying all systems have to meet the improvement targets for total and for the 2 subpopulations. Then systems are going to have to choose a different improving health equity measure. And so that's adding on another level of focus on reducing health disparities. Well, what's going to happen after 2022? We're actually figuring that out right now, but you most likely can imagine a scenario where the public healthcare system would continue working on the improving health equity measure that they chose, but more measures are going to look like this diabetes poor control measure, where you might now, instead of just diabetes poor control measure having 3 subrates, you might have breast cancer screening having 3 subrates and needing to meet improvement targets for the populations that have a documented disparity. You might imagine controlling high blood pressure having the same thing. So with that, it's sort of going to balloon and snowball over time in terms of accountability. Next slide. I just wanted to share this and wanted you to be aware of some of where this disparities data lives. I think one of our earlier speakers mentioned this, that these state level reports are produced by DHCS, and you can see the links on the bottom for the specific reports where I pulled this data from. But this data does guide, kind of where the state is heading in terms of which P4P measures they want to focus on for disparity measures, and for which measures systems can choose for their improving health equity. So these just show controlling high blood pressure on the left and breast cancer screening rates on the right. And the red circles just show where that particular race ethnicity had a lower rate than the white group for that particular measure. Next slide. So we talked about the design influence of Prime and QIP in addressing health disparities by standardizing data collection and by putting incentives in place to address disparities in care. Data collection is obviously critical. You can't even begin to identify what the disparities are unless you have standardized data collection. You're being incented to collect it and you're being incented to act on it. So that, to me to all of us was a critical first step in pushing a standardized focus across the state on this. But now I just want to touch briefly on another role that S&I is playing in this area. Next slide. So referring back to what both Dr. Penny and Dr. Wada said in their presentations, Prime and QIP focused on health disparities and which are the outcomes of inequities, but also inequities, right? So what SNI is setting out to do now is to support systems as they go further upstream, not just focusing on health disparities, but as they go further upstream to begin to address the inequities that lead to the disparities. And the top half of this slide is from an article that's very brief, but that I love because it says it much better than I could say it. And the link is at the bottom. But it talks about how racism itself is a structural determinant that drives the inequities in our community. That racism, has an influence on access to healthy foods, access to safety, access to economic inequalities, access to housing stability, education, and so on. And so it's really going upstream to look at that structural determinant of racism itself. So if racism drives many of these inequities, it can feel very overwhelming to think about what we can do as individuals, what we can do as organizations to address that. Well, what we're trying to sort of begin talking about in this racial equity community of practice is precisely what organizations can do to become anti-racist organizations. And the community of practice is launching in early 2022. Riverside is participating in it. And we're going to be supporting public healthcare systems in their efforts to begin to address the upstream factor of racism, both within their organizations and potentially within their communities, developing leadership capacity to make organizational change, and also to facilitate a shared understanding and a language around racial equity and health equity, and through peer learning and action. We think it's a fairly nascent idea. We're really excited about it. And I'm sure you might be hearing more about this, about our efforts as RUHS goes through the community of practice in the next year and a half. Next slide. So last slide, I just wanted to touch briefly on what the state is doing. We don't have a lot of information, although I understand that we might be getting an update on this tomorrow, so that will be hot off the presses. I don't have it today, but some of you have heard that the state, the Department of Healthcare Services, is developing what they're calling a health equity roadmap. And the last update that we have on their efforts was back in July. And at that time, DHCS shared that they would take a report that was commissioned by Sellers Dorsey to look at opportunities across DHCS for health equity. And they would kind of, take that report, lay it against the DHCS conceptual framework that you see a graphic of on the right, understand where there's overlap, where there's not overlap, and then engage in a stakeholder process where they'll ask folks from from across the state to participate. They haven't done that yet. But to identify where gaps are in their existing efforts against the recommendations from the report and this conceptual framework. So that's a lot of words. I think the conceptual framework gives us a sense of where they might be headed. Obviously they're talking about data collection and stratification. They're talking about looking at workforce diversity and cultural responsiveness. And they're obviously talking about ultimately reducing disparities. I think the list on the right shows you that they're trying to be very thoughtful about this not being a siloed approach. They're bringing managed care into it. They're looking at dental, behavioral health, CalAIM, and so on. So they're really trying to look across numerous initiatives and departments to have hopefully what we'll see is a more coordinated, strategic approach to how the state is acting on it. So I just wanted you to know that this is coming down the pike, and I anticipate very soon we'll have some more direction and coordination from the state around where their efforts are that's going to trickle down to us, right? And just to give you a very quick example before I finish, even though they weren't done with the health equity roadmap, one of the things that the state already took a recommendation from Sellers Dorsey on to put into practice was that when they were updating their Medi-Cal managed care plan contracts, one requirement now is that plans must have a health equity officer and a quality improvement and health equity committee. So they're already starting to put some of those recommendations into practice. And we know the state directs a lot of its initiatives and approaches through Medicaid managed care plans. And so that will trickle down to provider systems eventually. So with that, I will stop and see if there's questions.
So thank you to all of our speakers. Thank you, Giovanna, Dr. Wada, and Dr. Penny. We know that we're almost at time, and so I do want to turn it over to Dr. Kumar just to help us close. Thank you.
Thanks everyone for attending this grand rounds, and thanks especially to the speakers, Giovanna, Dr. Wada, and Dr. Penny. Thank you also to Ms. Monica Nagata for coordinating this and getting it together. We very much appreciate that. And a couple of housekeeping issues. So you may receive a survey after this grand rounds. And the survey is very valuable for us. It's a post survey, it takes a minute or two to fill out. Essentially asks you if the grand rounds met your needs. And then if you have any suggestions or topics for further discussion. So we would very much value your input on that. And I'll leave the screen on for another minute or so. If you want to grab CME credits, feel free to scan the QR code or get to this link, and it'll allow you to get your CME credit. So once again, thank you all for your time. We really appreciate all of your efforts on this. Thank you very much.